Okay, good morning. My name is Dr. Joshua. I'll be taking on the topic vitamin D deficiency and its relation to type 1 diabetes. We'll be going through these following subheadings: introduction, vitamin D physiology, the functions of vitamin D, classical and non-classical functions, talk about brief introduction to type 1 diabetes, the nexus between type 1 diabetes and vitamin D deficiency, result of 3 studies, and what my conclusion is. First of all, vitamin D is a fat-soluble vitamin. We also a hormone, and we know that vitamin D regulates calcium and phosphate. But beyond that, it's known that vitamin D has an effect in every cell in the body. Every cell in the body has a receptor for vitamin D called vitamin D receptor. And usually there's a daily requirement for infants, and that's why between 0 to 6 months, if you're exclusively breastfed, you should be on vitamin D supplementation. And if you are not breastfed, your food should also be fortified. And the requirement for infants is 400, and 600 is 70, above 800 international units. And for easy calculations, when you see 40 international units, it's equivalent to 1 micrograms of vitamin D. How is my vitamin D food? How do you get vitamin D? When this ultraviolet B from the sun rays hits your bare skin, it starts cascade of vitamin D formation, and which accumulates 7-dehydrocholesterol to cholecalciferol. Then your liver converts it to cytochrome P450, and also your kidney causes and add another hydroxy group to the 25 hydroxycalciferol. Diet is another major source. Other major determinants include your body weight. If you are obese, the cholesterol from the skin may be difficult or may not be absorbed sufficiently. Also, certain medication that alter the cytochrome P450 in the kidneys or that alter the environment of the intestine can prevent absorption of vitamin D. This is just a diagram showing the relationship between vitamin D, parathyroid hormone, the calcium, and the intestine. You get vitamin D. You get from how you get it from the skin or diet, and how the 25 hydroxy vitamin D can stimulate parathyroid hormone, and how parathyroid hormone can also act on the kidney to convert 25 hydroxy vitamin D to 125 hydroxy vitamin D. And also, when you have adequate amount of 125 hydroxy vitamin D, it can also inhibit formation of parathyroid hormone when the calcium is adequate. The physiology, vitamin D exists in 2 natural forms, the D2 and D3. The D2 is the one you see in plant, cholecalciferol, and the D3 is the one that's produced by the skin. When you take vitamin D from diet, trypsin and pepsin act on it and separate the binding proteins from the vitamin D. And through the help of vitamin B binding protein, it gets absorbed from the intestine, transported through the chylomicrons, and gets to the bloodstream, enters the liver, acted upon by cytochromes, and regulated in the kidney by PTH to 125 hydroxycalciferol. Okay, vitamin D binding protein is important for intestinal absorption and transport to tissues. And when it is mutated, it can actually lead to vitamin D deficiency. Vitamin D exerts its effect in cell by binding to a ligand-activated transcription factor, that's VDR. It forms a complex with vitamin D and binds to specific DNA sequence. Through this mechanism, vitamin D can regulate gene expression that is involved in calcium and phosphorus metabolism, that is involved with immune function, and many other physiological processes. And what are the classical functions? That's what we know from high school, how it helps in calcium absorption from the guts, calcium deposition in bone, renal calcium and phosphorus excretion, decreased PTH release from parathyroid gland, that's when it's adequate. Low vitamin D, it's important to know that low vitamin D levels leads to increase in PTH, which keeps calcium in the blood, and which also indirectly also stimulates out on the kidney to convert 25 hydroxycalciferol to 125 hydroxycalciferol. And it's important to know that taking high dose of vitamin D, such as through bolus, can lead to negative consequences. And boluses of vitamin D cause a rapid increase in 25-hydroxy D levels. This comes at the expense of regulating vitamin D, the active form of vitamin D, and at the result can alter all those functions I listed earlier, can affect the immune function and the rest. So what are the non-classical functions? Vitamin D is well known to be an immunomodulator. It has shown that if you are deficient in vitamin D, you are susceptible to infection and autoimmune disease. That's what we're talking about today, type 1 diabetes. There have been a lot of studies about vitamin D and cancer, as vitamin D is known to regulate apoptosis and cell growth. It is known to control neuromuscular function. It controls keratinocyte differentiation and function. That's why it's used in the treatment of psoriasis. It suppresses the RAS system. Deficiency in vitamin D can actually lead to hypertension, as related to hypertension, and also it stimulates insulin secretion. So vitamin D deficiency has also been linked to type 2 diabetes. Talking about type 1 diabetes, it's an autoimmune destruction of the pancreatic islets leading to insulin deficiency. This is a form of diabetes that's commonest among pediatric population. But we learned during this class that the prevalence is actually higher in young adults. There are genetic, dietary, and environmental factors that might interfere with its pathogenesis. And there are stages of type 1 diabetes. You have the stage 1, that's where you have presence of antibody with no abnormality. And usually 44 and 70% rates of these people progress within 5 years and 10 years, respectively, to type 1 diabetes. And in stage 2, there's actually autoantibody present and high blood glucose. This has 75% chance of progress to diabetes. Stage 3 is when there's development of clinical symptom. And it's important to note that once you have one of those stages, the chance of it progressing to type 1 diabetes is almost 100%. Now, at the level of islet, how does vitamin D affect vitamin D deficiency act on the level of islet? Now, when you have normal vitamin D levels, it decreases inflammatory cytokines, interleukin-6, and this actually decreases T cells recruitment, infiltration, and arrest of autoimmune process. So it means when there's deficiency, it will be reversed, and there will be increase in expression of interleukin-6, which will attract T cells, and it will infiltrate the pancreas and lead to autoimmune process. Also, there's decreased MAC1 expression with adequate vitamin D, which decreases attack by cytotoxic T lymphocytes. Reverse will be the case if there's a deficiency. At the level of the immune system, vitamin D deficiency, what does it do? It inhibits the differentiation and maturation of dendritic cells and promotes their apoptosis. It decreases TLPA1 cells and increases TLPA2 cells. It inhibits the production of interleukin-6, which is a direct stimulator of inflammatory marker Th7, which is implicated in many autoimmune diseases. So when there's a deficiency of vitamin D, it leads to a cascade that activate dendritic cells, monocytes. T1 becomes more than T2. TLPA1 cells becomes more than TLPA2 cells, and all these are inflammatory and leads to destruction of the islet cells. So this is just a diagram showing you dendritic cells. What it does, it increases interleukin-10 when there's a deficiency. And interleukin-10 is when vitamin D is actually adequate, what it does, it inhibits dendritic cells. Interleukin-10, which is anti-inflammatory, goes up. Interleukin-12, which attracts inflammatory cells, actually goes down. And if you look at it, you also notice that the TH1 cells, that's on the right, TH1 cells are inhibited, TH2 cells are brought more into action. But if there's a deficiency, the reverse is the case, and this leads to destruction of the islet cells. Now, what's the association between vitamin D and type 1 diabetes? There's actually strong evidence that low level of vitamin D is linked to type 1 diabetes. Adequate level of vitamin D during childhood has been shown to reduce the chance of getting type 1 diabetes. 2000 International Unit of Cholecalciferol daily in a large bed cohort study reduced the risk of type 1 diabetes by 80% in 1 year. And usually when you give vitamin D, it actually halts the loss of beta cells by the time of clinical diagnosis. But the thing is, when someone is known to be diabetic already, he has actually lost more than 80% of the islet cells. and this can actually limit the potency of vitamin D supplementation at that point. Screening for vitamin D is usually done by 2 years and 6 years due to the novel treatment with teplizumab, which is anti-CD3, that tends to halt the progression to type 1 diabetes. It is known that it is more cost-effective actually giving vitamin D than waiting for 2 to 6 years before you screen and start giving the very, very expensive teplizumab. 10 years ago, a small pilot study, prospective interventional trial demonstrated that daily treatment with a relatively low calcitriol dose effectively negativized tyrosine phosphatase associated insulin GAD antibodies within 0.6 years in all 12 seropositive children and 6.6 years and age 6.6 years at inclusion. 10 years later, when they follow up those population, none of the patients have developed type 1 diabetes or other type 1 antibodies. Now, in this study, it's a precast study done 2021 in Greece. What they did, they recruited up to 50 children for the study, and these are children at high risk of that. None of them had type 1 diabetes. The closest form they were to diabetes was they were already diagnosed with diabetes and they were not on insulin. So they had the children that were recruited were type 1 diabetes in first degree relative, those with high history of that, with strong family history were recruited, those with Hashimoto's thyroiditis or celiac disease, because it is strongly related to type 1 diabetes, and those with altered glucose metabolism, but they've not progressed to diabetes. Those with impaired glucose tolerance were also recruited in the study. So out of 2,696 children, they were able to exclude 311, that's those with clinical type 1 diabetes, and eligible children for the study were 50, 7 dropped out, 1 did not come for follow-up after 3 months. So the data that was worked on was 42 patients. Now, out of this, 28 had single antibody. Out of all those 42 patients, 28 had single antibody. 3 had new onset type 1 diabetes out of those with single antibody, but not yet on insulin. 2 out of them had pre-type 1 diabetes, and 9 had impaired glucose tolerance. 2 with positive IAA and 1 with positive insulin A2, who had presented with new onset type 1 diabetes, progressed immediately after diagnosis. And 1 boy with positive anti-GAD with pre-type 1 diabetes progressed to overt diabetes. The remaining 24 achieved seroconversion within 0.57 years. 8 with more than 2 or more antibody, that's the ones with 2 or more antibodies, 5 progressed to overt cases. The remaining 2 undergo seroconversion within 0.4 and 0.53 years. So from this study, what I want to bring attention to is that out of the 28 with single antibody, like the only positive to anti-GAD or anti-tyrosine phosphatase related isolated cell antibody, the ones that did not undergo seroconversion actually had clinical diabetes, but were not on insulin, or they had pre-type 1 diabetes, but the rest actually had seroconversion of those antibodies. Then for those that had more than 1 antibodies present, most of them actually progressed to type 1 diabetes. But those with HLA phenotypic predisposition, all of them actually negativized, like all the antibodies left. And how was this done? It was done with calcitriol and pre-calcitriol. They were started with the minimum dose, and after 6 months, they would check their blood level to see if the antibody has cleared. If it has not cleared off, the doses will be increased, and they will also be monitored for the side effects like excess calcium. They undergo urinary screening of calcium/creatinine level, and they also did ultrasound to check if there's stone. And nobody pulled out of the study due to these results. And for those that actually had urinary symptoms like polyuria due to calcium, due to stone, their doses were either reduced or converted to pre-calcitriol, which is 3 times less potent when compared to calcitriol, but 10 times less side effects. So because of that, you can actually triple the dose. You get the same potency, but less side effects. And the limitation behind the study was that there was no control to actually compare if most of patients with most of the patients would actually have negative, like to compare if they will actually undergo seroconversion. There was no way to compare. So that was the side effect. But why this study is known to actually show that there's actually a relationship between vitamin D and type 1 diabetes, that for the cases of relapse, when you increase the dose or when you continue the dose after stopping it, they undergo another seroconversion. So that's the strong linkage between vitamin D and type 1 diabetes in this study. In the second study, they were able to gather 12 children between 1 to 5 years. And this is a prospective trial to know if vitamin D should be used for treatment. And there was negativization of type 1 diabetes antibodies to GAD and insulin in children treated with oral calcitriol. 4 girls already diagnosed with celiac disease and autoimmune disease. And the truth is, even the vitamin D supplementation actually causes soil conversion in autoimmune thyroiditis and even in celiac disease. In all children, persistent seroconversion of the anti-GAD 65 antibodies and autoimmune to the insulin antibody was observed within 0.4 to 2.1 years. And of the 2 children with impaired glucose tolerance, the boy proved to have maturity onset diabetes. That's for the ones that do not have seroconversion. He actually had a different type of diabetes, which is maturity onset diabetes of the young. Then there was a systemic review where they combined 22 papers examining the role of vitamin D in cultured beta cells line, and 28 papers examining vitamin D in human or human isolates. The discussion reports strong association between type 1 diabetes and low level of vitamin D. There is also high level of evidence that adequate vitamin D status in early life reduces type 1 diabetes. In view of this outcome, the variable results in human trials are generally disappointing because they discovered that VDR polymorphism and type 1 diabetes and beta cell function, because they discovered that there could be what we call VDR polymorphism. So even if you supplement vitamin D, you may not see the adequate response. So most studies actually in the systematic review showed that the active form of vitamin D and other forms were predominantly ineffective. However, it is interesting that of all but one of the studies testing 25, the 25 hydroxycocalciferol reported benefits. So this suggests that maintenance of optimal circulating 25 hydroxycocalciferol levels may reduce the rates of type 1 diabetes, and that it may have potential for benefit in delaying development of absolute or near peptide deficiency. And it is known that 25 hydroxy vitamin D is actually does not cause harm and less side effects. So giving it to patients actually more beneficial. And even in the study, it shows that vitamin D, the less active form, is actually more potent and showed benefits. So in conclusion, I think I would recommend that vitamin D actually should be screened earlier than 2 to 6 years, not waiting until there is already the person are going to type 1 or type 2 stage of diabetes. For those at high risk, they can be screened for antibodies. IAA antibody can be seen as early as 18 months, and GAD can be seen as early as 13 months. So they can be screened as early as 12 months. And all children should be supplemented with vitamin D to reduce the prevalence of type 1 diabetes. Thank you.